All right, I'm Chris Chen. I'm a cancer doctor and assistant professor at Stanford. And on behalf of our co-authors, I'm excited to present our study, Mapping the Metastatic Spread of Cholangiocarcinoma. Here are my disclosures, and in particular, I just want to acknowledge gratitude for the generous support of the foundation and for the Scott family that made this work possible. So this study was motivated by a clinical scenario and dilemma that we face often, which is that for patients with cholangiocarcinoma who are diagnosed with disease still confined to the liver and lymph nodes, what is the optimal clinical strategy? Because some of these patients will have a prolonged period of localized disease, while others folks will quickly develop, unfortunately, distant sites of metastases. And arguably, if you knew a patient was going to have a prolonged period of localized disease, then surgical resection or liver-directed therapy such as ablation or embolization is the most appropriate strategy. Provides prolonged disease control while avoiding the side effects of chemotherapy, and most importantly, in the case of surgical resection, offers a pathway to cure. But if a patient in this situation is at high risk for developing distant mets, then systemic therapies like chemo might be more appropriate to eradicate circulating microscopic disease and hopefully prevent or delay distant mets. So arguably, which patient should go down which clinical pathway depends on the risk of distant spread, and trying to understand which folks fall into which category can be very challenging. And so we were really motivated to try to investigate how and why these different patterns of metastatic spread can occur in different cholangiocarcinoma patients. And this is obviously an enormous area of inquiry where a lot of different avenues can be taken. But in particular, we were interested in taking an evolutionary lens to examine this question. And that by using an evolutionary type of analysis, we could map the metastatic spread of cholangiocarcinoma in patients. And let me explain what I mean by that. So to borrow an analogy, when scientists are trying to understand the natural world and how evolution has led to different organisms, the rise of different organisms, one commonly used strategy is genetic sequencing. And that's because an organism that shares more of its genome with another is more likely to be more closely evolutionarily related. And this has been a critical principle in the pandemic when sequencing of different COVID variants, for example, have helped us understand how COVID is related to other respiratory viruses, and that's an example on the right, as well as how different variants have arisen around the world throughout the course of the pandemic. And so we can borrow this basic strategy of applied to cancer, which if we could obtain tissue samples from multiple lesions in a patient with metastatic cholangiocarcinoma, sequence each of them, and compare the relative similarity of the genome, we can understand which tumor lesions in a given patient are most closely related to one another, and therefore map and infer how metastatic spread occurred in a given patient. And previous work in colorectal cancer has illustrated the power of this type of work. And so there was a previous study done in which the authors asked, how are cancer cells in colorectal cancer in the primary tumor related to cancer cells in the lymph nodes and related to cancer cells in distant sites? And their key findings are shown in the schematic to the right. So the investigators on this study obtained tissue samples from 20 patients with colorectal cancer. And what they found is that in the primary tumor, many different cancer subclones are present, as illustrated by the many different colors in the primary tumor. And if you examine the lymph nodes in these patients who had lymph node positivity, many different types of cancer subclones could be present in those lymph nodes, as illustrated by the different colors. But only a very small isolated subset of cancer cells could escape to distant sites. And what that implies is that lymph node positivity in colorectal cancer isn't necessarily always an accurate predictor of the risk of distant spread, which is a very powerful idea and I think foreshadowed what is now emerging clinical trial data that demonstrates that circulating tumor DNA may be a better biomarker for those at highest risk for distant spread, as opposed to traditional clinical characteristics like lymph node positivity. And so, but one big challenge of this type of work is it requires multiple tissue samples from a single patient. And obtaining clinical biopsies in this setting is challenging because of the clinical risk it confers. But at autopsy, there is the unique ability to obtain tumor tissue from multiple anatomical sites. And so this work was started has been done at Massachusetts General Hospital, where Dr. Dan Urich launched an autopsy program, and Dr. Lipika Goyal has led a multi-year cholangiocarcinoma effort there. And over the years, 16 patients with cholangiocarcinoma who have been treated at Mass General have generously participated in this program. And from 16 patients, a total of 251 tumor samples from liver, lymph nodes, and distant sites, as well as 36 normal samples have been collected, and whole exome sequencing has been performed. And we're now working with the group of Dr. Camilo Naxarosa, who is a cancer evolutionary mathematician at Mass General, to understand and build out maps of metastatic spread in each of these 16 patients. And today I'm going to show examples from 2 patients out of these 16 that illustrate some initial hypotheses and have to set the stage for our next steps of analysis. And so the core of our analysis has been developing what are called phylogenetic trees for each patient. And these are ways of visualizing how different tumor lesions in a given patient are related to one another, and allow me to explain with this example on the right. So this is an example of a phylogenetic tree, and each terminal point on the tree where there's a label represents a different tumor lesion that was taken at autopsy. The relative distance traced along the tree represent the relative genomic similarity between 2 lesions. So for example, between livers 1D and 1E, the relative tree distance is shorter along the tree as opposed to, for example, liver 1D and liver 2, which indicates that liver lesions 1D and E are more closely related to one another. And then each branch point in the tree illustrates a common evolutionary predecessor. So for example, liver 1D, E, and C in the upper right, because there is a common branch point from which all 3 lesions emerge, it indicates that all 3 tumor lesions came from a common cancer clone or subclone. So this specific example is from a 57-year-old woman who was initially diagnosed with cholangiocarcinoma in her right liver, and it was surgically resected. She received adjuvant chemotherapy, but unfortunately subsequently relapsed in the lung and the liver. And there are a number of notable things we could talk about, but the critical finding, or one of the most notable findings to us, is that we highlighted the patient's distant lesions in blue, her lung lesions. And what we see is that this patient's lung lesions cluster distinctly from the majority of the patient's liver lesions, that they're in their own separate, what we call evolutionary clade, and as outlined in the dotted red circle there, in which there are some liver lesions are included, but the majority of her liver disease sits outside of this branch point in her phylogenetic tree. Sorry. And this is in stark contrast with the second patient. And this patient is a 58-year-old woman who unfortunately had metastatic disease at diagnosis with both lung and liver mets present already. And her phylogenetic tree is displayed to the right. And in contrast to the previous patient, in which we observed how the lung lesions clustered distinctly from the rest of her liver lesions, we see here that there is no distinct branch point for her distant lesions. The lung, liver, and lymph nodes are all clustered and unified within a common branch. And so, why do we care about this biologically or clinically? Well, what this really suggests is that for patient 1, in order for the cancer clones in the lung to be able to seed the lung and see distant sites, there had to be that the majority of her liver lesions did not have that initial metastatic potential. That was only when a subsequent common cancer clone developed that was capable of spreading were the lung lesions finally seeded. And that is distinct from patient 2, where the fact that there is a unique clustering suggests that a significant proportion of this patient's disease was capable of seeding distant sites without requiring additional evolution and additional gain of that metastatic potential. And so in reflecting on why these 2 patients presented differently, with patient 1 presenting with initially resectable disease and patient 2 presenting with metastatic disease, one could argue perhaps it was simply the time point. Patient 2 was diagnosed later. And of course, that certainly is likely an important factor. But what the trees also suggest that that's not the whole story, that patient 2 likely had a biologically distinct form of cholangiocarcinoma that had conferred much greater metastatic potential because a much greater proportion of her cancer was capable of seeding distant sites, and that the cancer in patient 2 looks and behaves something very differently. And so that's an initial conclusion that has generated excitement for our work. And phylogenetic trees for the rest of our cohort are being developed, and a number of different mapping techniques are being utilized. And our hope is this work will continue to generate insights, how and why different patients have different patterns of spread. We want to, of course, thank the profound generosity of our patients who participated in our autopsy program, the generation of the foundation and the Scott family, and to our collaborators and co-authors, in particular Dr. Goyle and Dr. Naxarosa. Thank you.
Thank you very much, Chris and Bridget. Welcome to the cholangiocarcinoma family. We look very forward to seeing how your projects develop and seeing the results in the next couple of years.